So welcome everyone to a webinar on substance use in pregnancy and breastfeeding. My name is Lisa Graves. I'm a family physician by training. My academic appointment is as a professor of family and community medicine at Western Michigan University Homer Stryker MD School of Medicine in Kalamazoo, Michigan. I've been involved in substance use in pregnancy and in breastfeeding for well over 25, getting close, 20, close to 25 years. I currently also continue to have a practice focused in addiction medicine in Northern Ontario. So I sit a little bit like many of you in this world that exists with women who have problematic substance use and who are also pregnant or parenting. I wanted to make certain that everyone knew before I started I have the following conflicts of interest to declare. I am the project lead for the Association of Faculties of Medicine Canada's response to the Opioid Crisis Project. I'm a physician with an interest in addiction medicine. I'm an employee of the medical school, and I currently hold grants from the American Academy of Family Practice, the state of Michigan in primary care HIV, and through the YWCA in Kalamazoo related to reducing infant mortality. What I really wanted to spend some time talking about today are really sort of what are the evidence for related to substance use in pregnancy and breastfeeding for the four major substances that I think preoccupy us the most currently as Canadian physicians. I wanted to sort of talk a little bit about the challenges that exist within this population, and really to give you some practical suggestions. I would be very disappointed if at the end of our time together today that you left without feeling you had at least one tool that you might consider using in women that you see as healthcare providers in order to actually start to change the trajectory for the health of women and the health of their families. Throughout today's presentation, I'll be using the term women. That is for simplicity's sake. It is not meant to exclude anyone who may be pregnant or parenting and does not identify as a woman. So let's get started. We're going to start a little bit talking about sort of the four substances, a little bit of interjecting some ideas and tips that might be useful, and then finally concluding with with a little bit of focus on the SBIRT technique and how it can be a really useful tool to use in day-to-day practice. So marijuana is a fairly common substance. We know that based on the National Cannabis Survey in 2019, that 15% of Canadians reported using marijuana in the previous 12 months. That probably isn't a surprise to most of us. Antenatal records examined in Ontario showed at least 1.4% of antenatal records showed that cannabis was being used during pregnancy, and we strongly suspect that that number may well be an underestimate. Antenatals from records from British Columbia have demonstrated an increase in cannabis use in pregnancy from 2.2% in 2008 to 3.3% in 2016. And again, that data is probably not surprising because it really does speak to the changes that legislation and availability have made in terms of not only the use, but the perception of use of marijuana during pregnancy. I'd be remiss when we talk about marijuana, not to mention the fact that this discussion around marijuana itself can be very confusing for some of our patients. And that's because we really are talking about the two major substances that we currently find in marijuana, THC and CBD. The THC is essentially the component of marijuana that causes the euphoria, the high, and can present withdrawal symptoms in 25% of the population. The CBD does not have the same psychotropic effect. And when you look at the literature, the literature, most of the literature relates to the effectiveness of or the use of THC. There's much less literature on CBD. However, many of the discussion that's centered on the health benefits of marijuana focus on CBD and not THC. So again, it's this discussion that becomes really challenging for patients to understand what's in the public domain, what the discussion is. And it really behooves us as healthcare providers to work with our patients so that they understand not only what the difference is between THC and CBD, but really the paucity of evidence that exists currently around CBD and THC. It's also important that we educate our patients as consumers. The quality control for THC is different than the quality control for prescription medications. And so there can be significant variability at the percentage of THC, for instance, that's available both at dispensaries and off the street. There's probably a greater likelihood that dispensary-based cannabis is likely to have better quality controls. However, as many of your patients may report, it may be more expensive than cannabis that's bought off the street. So there's a lot of confusion that exists around THC and CBD. So it's important in discussion with women to really be frank about the evidence that we do have and the evidence that we don't have. Certainly with edible products, we know that there can be some inconsistencies. There's delayed effects that can happen. And a 2015 report in JAMA, again, indicated just some labeling inaccuracies. Although not a medical study, similar reporting in Canadian newspapers has demonstrated the same sort of variability that can occur in some products. So again, women need to be aware that what they are consuming may not necessarily be what they think that they are, what they believe that they're getting. And if we believe, according to the literature, that the impact of cannabis during pregnancy is a dose-related response, then knowing that percentage of THC is important. It's also really important to remember that over the last 20 to 30 years, the percentage THC in cannabis has increased. And what that basically means is that cannabis that used to be 3% THC is now 9%, 12%, and higher. So again, when we think about looking at the literature, even some of the more recent studies were dealing with THC content that was 3 to 6%, and our patients have the ability to get 2 to 3 times or more that percent THC. So again, if we think about it in a dose-related response, it really, again, is important for us to be having these conversations with women as they think about cannabis use and they think about, again, their reproductive health. We do know that cannabis has been linked to an impact on children who are exposed to cannabis in utero. There are really 3 studies that have tried to contribute to our understanding. I think it's really important in any talk about substance use and pregnancy that we highlight the fact that it's really difficult sometimes to do these studies. Women who are substance using are often using more than one substance at a time. There are many impacts related to the social determinants of health that play out in terms of determining birth outcomes. And so it becomes a real challenge to sort of tease that out of the literature. The other thing is what we've learned, certainly from following children who've been exposed to alcohol during pregnancy, is that some of the impacts of in utero exposure are not seen at birth, but they're actually seen a significant number of years later. So following children long term, 10, 15 plus years out from the in utero exposure really helps give us a better idea of what's happening. These are 3 studies that were longitudinal, and that tried to control for some of the social determinants of health. And basically what they found was that in certain age groups, there were absolutely differences and deficits that were noted. So deficits in memory, perceptual skills, verbal and visual reasoning in the preschool set. At school, for school-age children, impaired performance in reasoning, short-term memory, reading, spelling, and other forms of achievement. And moving throughout the lifespan, and particularly into adolescence, more issues with attention deficit, increased hyperactivity, and impulsivity. We also know that there are some studies that show, again, some evidence of impact at birth. The Elmaroon study of 2009 is, for me, particularly relevant because it looked not only at, it looked at birth outcomes and not only looked at growth restriction and lower birth weight, but actually is one study that really does suggest that there's a dose response effect present. And that's really important because if women are reluctant or unable to reduce their cannabis use, it can be really helpful to let them know that we have some literature that suggests reducing the amount of cannabis that you're using can actually have a benefit towards outcome. This is a lovely picture that I often like to use with patients that really shows the impact of cannabis across the lifespan, showing, from small children, 18 months, through to adolescence and young adulthood. And it's a very nice visual representation of the information that I've just presented. The other thing to remember in conversations with women who are using cannabis is that tobacco can be mixed with cannabis. And that potentiates the impact for many women of the cannabis use. And so when you're talking about stopping cannabis or cutting down on cannabis during pregnancy, it can be really important to ask if they're mixing their cannabis with tobacco. Because again, one of the simplest things to do in order to look at reducing cannabis use is to separate the tobacco from the cannabis. It is more challenging for women to stop cannabis use if they have been mixing it with tobacco, because you have the nicotine dependence as well as the potential impact of cannabis. And sorting the two out lets you understand what it is you're addressing. Is there actually a cannabis dependence, or is there actually a nicotine dependence? And it means that you may sometimes have to use some combined techniques in order to address both. One way that we can sometimes deal with this is to help women, as I said, reduce the amount of cannabis they're using. An inexpensive kitchen scale can allow women to weigh their cannabis and actually start to calculate out reducing it by 10% per weight of their daily amount per weight during a week. And again, by separating out the tobacco and cannabis, we can make really certain that we're helping women address the issue. Is it cannabis or is it tobacco? It's also important to remember with cannabis in the immediate postpartum period that significant cannabis use in women who are very cannabis dependent or heavily using can actually change pain perceptions. That we may need to use nicotine replacement therapy for women in hospital who have been using tobacco concurrently with nicotine. That sometimes acute withdrawal from cannabis may actually make someone look like they're high. And there's been some suggestion we could use Nabilone off-label for those acute withdrawals, again, from someone who was using significantly and experiencing acute withdrawal. Babies can experience some form of cannabis withdrawal. It's not particularly well documented. There's no need to use something like the Finnegan scale, which is actually designed for opioid withdrawal. But again, many infants who've been exposed to heavy amounts of cannabis have also been exposed to other substances, and the infant may be having issues related to those other substances. It's always a good point in time to remember that infants that are experiencing symptoms postpartum just because mom is substance using or substance dependent is not a reason to exclude other diagnoses in the newborn period, with sepsis being one possibility. Again, babies do well postpartum. They should be kept in hospital for 48 hours just to make certain that they continue to do well, that they're feeding well, that parents are able to soothe them, and that again, babies are particularly in terms of their nutrition are able to suck well, that there's no discoordination of that effect. The SOGC has been pretty clear about marijuana use during pregnancy. And it recommends that women who are pregnant or contemplating pregnancy should abstain from cannabis use during pregnancy. Similarly, major organizations, including the SOGC, have suggested that it is prudent to avoid marijuana use while breastfeeding. The literature around breastfeeding and marijuana is very scant. Much of the literature is difficult to tease out because you are looking for a group of babies that were exposed to marijuana only during breastfeeding and not during the antepartum, antenasal phase of their development. And many studies have only very small groups of infants that actually fit that criteria. However, extrapolating from the in utero literature and looking at, again, the results the equivocal results from these small group of infants, it seems to be the prudent choice to recommend to women that cannabis use not occur while women are breastfeeding. Of interest, there does seem to be a slight increased risk of sudden infant death that seems to vary a bit. And certainly there's at least one paper that suggests paternal cannabis use has been associated with an increased risk of SIDS, again, a small number of infants. So as healthcare providers, it is prudent to say that, to tell women that the prudent choice while breastfeeding is to avoid cannabis use. I included a slide here around postpartum issues that partly pertains to women with cannabis use disorder, but actually pertains to any woman with a substance use disorder. Child Protective Services, Children's Aid Societies, it's really important that as providers who know patients well, that we advocate on behalf of women and the woman and her child for the services that she needs in order to parent and parent appropriately. What additional supports might be available to support women who are both pregnant with a substance use disorder and who may be parenting. And again, this is an opportunity to work collaboratively with our colleagues in social work to really help women avail themselves of some of the programming and counseling that may be available to them. This is also a great opportunity to discuss with any of our patients the ability to parent while impaired. Cannabis use, and for that matter, other substances and alcohol use, all can result in a parent who has some level of impairment or challenges looking after a dependent newborn. And I have started having conversations with many of my patients who are pregnant and who are postpartum around the concept of the designated parent. Who is the adult in the house who will be available to make certain that the newborn, as well as other children in the house, are appropriately taken care of should one of the parents be impaired? And it's a really important conversation to have because the concept of designated parent applies across the spectrum and not just to women or families where there's a substance use disorder. Spent a fair amount of time on cannabis, and that's because there's actually a little bit more information around cannabis, and it is a bit more common. Another substance that's commonly seen in the Canadian system and amongst women who are pregnant is cocaine. It results in an intense euphoria, and with chronic use, that brief euphoria can be followed by agitation and paranoia. The withdrawal symptoms from cannabis are primarily psychological. Insomnia, anxiety, fatigue, increased appetite, which is not necessarily psychological. There are some risks with each cocaine withdrawal episode of relapse and suicide, that often associated with the withdrawal from cocaine. But the important thing with cocaine is there's no specific medical therapy that has been shown consistently to work for women who are cocaine dependent. And so unlike opioids, for instance, where there is a pharmacological treatment, we don't actually have a specific pharmacological treatment for cocaine specifically. We know that cocaine impacts on obstetrical outcomes, increasing the risk of spontaneous abortion, small for gestational age infants, prematurity, stillbirth, etc. We're not so certain about the long-term impacts of cocaine exposure in children. We certainly suspect that there are some expressive and verbal comprehension delays, more behavioral problems at school, but as we follow some of these children for longer periods of time, it's uncertain whether or not all of these impacts persist. And following that data and starting to understand what that looks like will be really important in making certain that children who are cocaine exposed, if there are long-term consequences, get the support that they need in terms of the educational system. Definitely, again, with cocaine, there's a dose-response relationship. So again, it's really important for women who are using cocaine to strongly encourage them to if they cannot stop cocaine, to try and reduce the amount of cocaine that they're using. And you can use some of the same techniques that we discussed with cannabis. Probably the key point in dealing with a woman who has disclosed that she has a cocaine use disorder is to let her know that it is safe to stop cocaine suddenly. Many women think that you have to taper off cocaine in the same way that you need to taper from opiates. That's actually not true. Women can actually stop cocaine suddenly. There's really no treatment that you need to put in place to cope with that sudden withdrawal. You may provide some short-term benzodiazepines to treat anxiety and insomnia, but being very careful that this does not become a long-term solution for women, because as we know, benzodiazepines in and of themselves can lead to dependence. Managing of pregnant women dependent on cocaine, again, commonalities with addressing issues for women who are substance use dependent is to really support and encourage program attendance and treatment program, offer counseling to support women in her choices, provide comprehensive prenatal care, and do what we can to address safe housing and adequate food and any other social determinants of health that are at play in this woman's life. Certainly, if a woman is intoxicated at the time of delivery, the neonate may experience some central nervous system effects such as poor feeding and sleeplessness. But in reality, a baby born to a cocaine-dependent woman should be treated like any other neonate. Rooming in and cuddling is perfectly acceptable. Since cocaine enters the breast milk, it's best to avoid breastfeeding, and this is where there's some controversy. The recommendation is usually within 3 days of use. Some sources have suggested it could be as little as 24 hours. And so again, the standard has been 3 days, but we may see that number actually shifting downwards as we have more experience with women who are cocaine dependent and breastfeeding. I wanted to put a few words in about methamphetamines, mostly because we don't know a lot. But we are starting to see methamphetamines as an emerging substance in the Canadian landscape. There's a lot of concerns that come when women are using methamphetamines, and they're listed here. We know that there are adverse fetal outcomes that are associated with methamphetamine use, and we know that methamphetamines crosses the placental barrier. But there is a real gap in the literature around understanding what the potential outcomes are for methamphetamine exposure, and more importantly, what are some optimal treatment regimes. So please stay tuned to what comes up and is there with respect to methamphetamines, because we're certainly expecting to see some changes in the future. So let's finally go to opioids. We are sitting in the middle of an opioid epidemic, and preparing this webinar in the midst of the COVID-19 pandemic, we are seeing some shifts in the opioid using landscape that may play out in the future of women who are becoming pregnant and who will be pregnant during COVID-19. That's a topic for another day. Opioids really classically show a lot of the signs that that allow us to tell whether someone has a substance use disorder. And really, a substance use disorder with opiates is very profound, the dependence, but you can actually use these as markers for any other substance that you're trying to sort out as a woman, just a casual user of a substance, or does she have a problematic substance use disorder or a dependence? And that's tolerance. Larger and larger doses needed in order to get high, to achieve the euphoria. A significant amount of time devoted to getting or taking the drug. And really a move away from doing all of the things that an individual should be doing at their particular age and stage of life in order to actually make certain that they stay out of withdrawal, because withdrawal is frightening. The risks of an opiate-dependent pregnancy are listed here. Smaller babies, a greater risk of premature labor. Opioid withdrawal, so that when women stop opiates suddenly in the first trimester, can lead to a spontaneous abortion, and premature labor in the third trimester. It also increases the risk of preeclampsia as well as antenatal bleeding. And heroin in and of itself has been associated with intrauterine growth restriction. So it's also important to make certain that there are a small group of women who are on prescription opioids for medical reasons that actually don't develop a dependence. They stay on the same dose for years. Their infants are still at risk for neonatal abstinence issues, but they have a different profile in terms of risk management. It's also important to recognize that women who are opiate dependent and have an opiate use disorder can function on massive amounts of opiates um, um, that again are well beyond what we would normally prescribe for someone. And that tolerance can disappear after days, which is why we tragically see um, deaths from overdose from individuals who go back to using a dose that they've used before they stopped opiates, and suddenly they have lost their tolerance. Opiate withdrawal is frightening for many patients. There's tremendous psychological cravings and restlessness. They're physically, in pregnancy, there's uterine irritability. It feels to many patients like one of the worst flus that you've ever had. And so it's not surprising that patients will do whatever they can to avoid that feeling. You can taper opioid use during pregnancy. Slow tapering has been reported in individuals with low to moderate doses. Um, but in women who are truly opiate dependent, and I would prefer, my apologies for using the word addicted instead of dependent in that slide, that's an error. It's rarely successful in patients who are truly dependent. Because again, they just don't seem to be able to tolerate the withdrawal. And again, a relapse during pregnancy for someone who has previously been managing well can have really catastrophic impact, leading to issues with their, particularly with their family and their family structure. So again, if women have an opiate use disorder, they really should be referred to an individual who would start them either on buprenorphine, naloxone, or methadone. And certainly, unlike cocaine, opiates should not be stopped suddenly during pregnancy. And so if you are experiencing a delay getting women into a program to treat their opiate use disorder, it is reasonable to continue their prescription opioids until that can be arranged. There are two options that are safe during pregnancy for opioid use disorder treatment. One is methadone, been around for a long time, works well. You can start it inpatient or outpatient, depending on what the resources are. And methadone maintained pregnancies have reduced obstetrical complications and improved outcomes. Buprenorphine is another molecule that works for opiate use disorder. Buprenorphine is safe during pregnancy. The Mother trial in 2012 found both good maternal outcomes and that infants had shorter abstinence syndrome periods than on methadone. And again, in 2016, one of our Canadian colleagues have published, again, the finding that the outcomes were good for buprenorphine and naloxone. We're still dealing with a relatively small number of infants that have been born and followed on buprenorphine and naloxone. We expect that the outcomes should parallel the Mother trial, and that we know that naloxone alone is safe during pregnancy. So if you put the two together, we believe the combination should be safe. The 2017 guide recommended caution around the prescription of buprenorphine naloxone. I think that we can anticipate seeing that change in a set of guidelines that may be appearing in the SOGC shortly. It's important to remember that that not all women will experience relief with buprenorphine naloxone, and women whose needs are not being met in terms of relief from craving and withdrawal from buprenorphine should be switched to methadone. We talk a lot about neonatal withdrawal, and certainly it is an important and distressing event when it occurs. It occurs 2 to 4 days after birth and can last sometimes for a significant period of time as the baby clears the medication from its system. It's marked by poor feeding, irritability, crying, jitteriness, and poor weight gain. Interestingly enough, morphine, which is the most common medication we use in Canada to treat neonatal withdrawal, is often not necessary. Comfort measures such as breastfeeding and rooming in and cuddling have been shown to decrease the need for pharmacological treatment of neonatal withdrawal. It is safe to breastfeed on methadone and buprenorphine naloxone, regardless of the dose. There have been a few case reports related to infants who have had unfortunate outcomes while being breastfed on either of these molecules. The reality is that a deeper dive into these case reports has not substantiated that we could feel that it was methadone or buprenorphine alone. Certainly, one of the lovely things about the fact that infants who are born to women who are on methadone, buprenorphine, do spend a few more days in hospital being observed, it is a great opportunity to make certain that that women are aware on how to recognize if their infant is having a health issue, whether it's related to a concern about methadone or buprenorphine, or whether it's related to other issues in terms of care. And that's why, again, rooming in is such a wonderful option if it's available and if it is a safe option for mom and baby. It really does allow an opportunity for women with opiate use disorder to attach and practice good parenting and supported parenting while they adjust to their newborn. Postpartum care, again, for women with opiate disorder parallels the postpartum care for any woman who is experiencing a substance use disorder. The social support, community supports, ongoing care for substance use, making certain that we recognize that just because women aren't pregnant, we still need to make certain that we absolutely carry on providing for her excellent care. And again, addressing all of those social determinants of health. I wanted to very briefly conclude by making certain that I left this webinar with a few thoughts around what it is we can do. Throughout the presentation, I've talked about reducing use, reducing amount of substance use, talking about dose-response relationship. All of this should come in a context of something that is often referred to as SBIRT, which sounds long and complicated, but actually can be a quite brief intervention in the provider's office. Screening, brief intervention, and referral to treatment. A brief intervention is quite time limited. They are counseling strategies or conversations. They've been really used in and really researched well in alcohol use, but in fact they translate very nicely over into any of the cocaine, methamphetamines, marijuana, and opiates. And it really is thinking about this in terms of, you can either think of it as a triple A or three A's, whichever memory device works well. But first of all is raising awareness, sort of assessing, are women ready to change their habits? It's providing some advice, and then it's offering assistance in sort of seeing how some of that advice can go. This is not a 30-minute, 40-minute intervention necessarily. It can be relatively brief if you think about readiness to change, providing some digestible advice, and then offering assistance in some areas. Again, the evidence for brief intervention is there. This comes from the alcohol literature, but again, we see wonderful parallels that exist in the other substances. And I think for me, the key point in this is that the length of time can be as little as 5 minutes. And that feels very doable as a healthcare provider with a busy office, with multiple demands on our time. And again, and the number of sessions that may be needed to actually affect change can be as little as 1 or significantly more, certainly in the SBIRT interventions that were tried. So again, it's really important to take a step back and feel empowered by the fact that we are able to offer brief intervention probably more frequently than sometimes we think, or that we may in fact be offering brief intervention and just haven't recognized it as such. One of the brief interventions that's most commonly used, and again has been shown to be very effective, is motivational interviewing, which involves a goal-oriented communication style, really focusing on personal reasons for change. Why does the woman herself want to change? Not why do we want her to consider change, but what does she see as the benefits for her changing? Motivational interviewing has been shown to be better than traditional advice giving, and it actually takes about the same amount of time. So framing that A of the advice session the advice section of those triple A's is really thinking about motivational interviewing. Again, really can change the outcomes of what it is that we're doing in each of our clinical settings. While motivational interviewing is sort of the gold standard for the SBIRT in terms of the brief intervention, harm reduction, so again, used quite a bit with alcohol, certainly methadone and buprenorphine naloxone are two examples of harm reduction. Really takes a strength-based approach, focuses on achievable goals, and really is designed to reduce some of the stigma around substance use, which is often the stigma that stops women from reaching out for counseling and additional social supports. So if we think about SBIRT, screening means asking everyone. It means being willing to enter into a conversation with anyone who comes into your office, any woman who is pregnant, around the substance she uses and assessing her readiness for change. The brief interventions can be one session to multiple sessions. It can be as little as 5 minutes. It can involve motivational interviewing. It can involve a discussion around harm reduction or many other techniques that are well beyond the scope of this short presentation. And finally, the RT of the SBIRT mnemonic really refers to the fact that if you're doing the screening and the brief intervention, it really needs to be paired with referral and treatment for women for whom referral and treatment is appropriate. And this, again, does not need to be complicated. For some women, it may be ongoing discussions with you as a provider, assessing her willingness to change and her readiness to move forward with potentially more intensive treatment or counseling, all the way through to referral to inpatient or medical assisted treatment modalities. Either of those things, again, are things that, again, should be part of our regular conversation with women in our practices who are substance using. So I hope in the context of this brief webinar that I've been able to provide you with some information to underscore the importance of having conversation with women as providers about cannabis use, about methamphetamine use, about cocaine use, and about opioid use. I hope that you have left this session with at least one idea of how you might incorporate change into your practice, knowing that since you're screening all women in a non-judgmental manner, that again, a brief intervention, however small it may be, however brief it may be, is useful in helping women in their journey to being healthier and to having healthier families. I am more than willing to provide references for this presentation on request. And I thank you very much for the time to share some of my thoughts on caring for women who have substance use issues and who are pregnant and who will be breastfeeding. Thank you very much.